Hey guys, welcome to Man Medicine, where we talk about how men can optimize their health and escape the collapsing U.S. healthcare system. I want to do a little talk with you guys today about elevated liver function tests and how it relates to exercise. This has come up on a number of occasions throughout my career, not just with patients, but actually with myself. So I thought I would share some insights just to educate you guys a little bit about maybe the ways that your doctor might approach this particular problem. If you, let's say, you go into their office for maybe like a routine annual physical, whatever the case may be, and you have these small liver enzyme elevations. And we're going to kind of focus in on the AST and the ALT because those are the ones that perhaps most people are familiar with. But there's actually a number of other liver enzymes that your doctor is going to look at as well to try to piece it all together. This is something that is extremely common, and as I'm going to show you guys, in many cases, it doesn't necessarily reflect like serious liver pathology. I'm hoping that this will also relieve a little bit of anxiety that you might have if you get a report back and you see the red H, by the AST and the ALT, and I don't want you to freak out and lose sleep over that. I do want you to see your doctor, obviously, about it, and make sure that there isn't anything more serious going on. And we'll talk a little bit about that workup, but for the most part, especially if these are just minor elevations, we're talking like less than perhaps like twice the upper limits of the normal range. Oftentimes it's a benign cause or relatively benign cause. Sometimes it does represent serious pathology. So my intention is not to have you guys like blow this off clearly or just assume that it's related to exercise and not get it worked up further, but rather just to give you guys a little bit more information about the things that will be going through your doctor's mind when they look at your labs. Assuming your doctor is familiar with working up liver enzyme elevations, which most internal medicine, family medicine docs, nurse practitioners, PAs, etc., will have some experience with that. But it does vary. There are many docs that have a very limited understanding of the liver and will want to refer you to a specialist right away. Hey, you know what? And that's okay, as long as you get the expertise and the care that you need. I suppose it doesn't matter necessarily where it comes from. So, again, this is extremely common. The focus today is going to be on exercise. So specifically like heavy weight training, the effects that can have on your liver function tests. And again, specifically AST and ALT. And I do want to touch on this because even though, like I said, the majority of physicians and, other healthcare providers that practice in the conventional medical system, we have training, especially in the primary care world, about how to at least initiate a workup for this. But you'd be surprised, like many docs don't necessarily or they don't think to ask about your exercise regimen, and they perhaps don't understand that heavy exercise, weight training, etc., can actually be one of the primary causes for these mild LFT elevations. And if they recognize that, it can often save you from like a very extensive and often very expensive workup that could, in some cases, lead all the way up to a liver biopsy, which you don't want to have unless you absolutely have to have that. So, with this information, who knows? Maybe you'll educate your doctor or your provider a little bit if they're not aware of this. It's in med school they teach us to hunt for pathology. Perhaps we don't get as much training as we should in hunting for some of the more common benign things. And this is something that I've run into. It's something I've run into personally because my liver enzymes are frequently just a few points above the reference range, and they've been that way my entire adult life. I've gone through 2 full workups for this when I was on active duty because I would transfer to a new duty station. I would get a new primary care provider, and it would make them nervous, and they would initiate a full workup all the way up to and including a liver ultrasound. I've never had a biopsy, and I don't ever plan on having a biopsy. But the point is, in my case, this was entirely from exercise. I would stop exercising for a period of time, and we'll talk about what the optimal period of time is, and then these enzymes would all normalize. But I was happy to have an extensive workup because, again, you don't want to just assume that these enzyme elevations are solely from exercise, blow it off when it turns out that maybe you do have some underlying serious condition. So anyway, with that in mind, let's let's talk about this case study here. This is a paper, it's a case report actually written up in the 2023 edition of the Journal of Family Medicine and Primary Care. It's a pretty good, like, overall primary care journal. It's called Exercise-Induced Increases in, quote, liver function tests in a healthy adult male. Is there a knowledge gap in primary care? And yeah, of course, yeah, the answer is yeah. In some cases, there is a knowledge gap. So what this case study is, it looks like it was back in October, yeah, October 2021. So this is the case of a otherwise perfectly healthy 39-year-old male who exercised regularly. He was primarily a runner. So he would run, they said, between 30 and 40 kilos. He would run like 30 to 40 kilometers a week, and then he engaged in regular weight training. I would have liked it if they were a little bit more detailed about what this guy's lifting program was, but I'm assuming that he probably, if he was running, if he had that kind of running volume, he was probably lifting weights 2 to 3 days a week, as to supplement his cardio from his running program. So they mentioned he was, like I said, otherwise perfectly healthy. No other medical conditions. He took no prescription drugs. He did not drink alcohol. He did not smoke. And most importantly, or also importantly, he didn't take any nutritional supplements. So this guy was kind of a blank slate. And they found these elevated liver enzymes. This is the table here from the paper, chronological trend in liver function tests. So they had data on this guy going back to 2010. And for most of these values, he was always like right at the upper limit of normal for his AST and ALT, occasionally went over a little bit. But, these earlier values in 2010, 2013 were all, they're pretty benign. Like most people wouldn't raise an eyebrow over most of this stuff. But back in, where was it here? They said in October 2021, they said he was overseas where he got these values, and his alkaline phosphatase, which is a liver enzyme we'll touch on briefly, was a bit elevated. And it had been elevated before, although not quite as high. He saw somebody, and they said, "Hey, when you get back home, like just kind of get this looked into." So that's what prompted him to come in March of 2022, and that's where, like, for the first time, now we're starting to see some, significantly elevated AST and ALT values, in addition to a couple of his other LFTs. So his alanine transaminase, so ALT, and aspartate transaminase, which is AST, 96 and 49, obviously both above the upper limit of normal. Alk phosphatase is trending down, but still a little bit elevated at 128. That doesn't get me terribly excited. The alk phos. So what his primary care physician did initially was perfectly appropriate. They said, okay, that's a little weird. You're asymptomatic. You're totally healthy. Why don't we just repeat this in a week? So just like, don't do anything differently. Just come and see me in a week. We'll repeat it. If it's still high, then we'll initiate a workup at that point. Totally appropriate. And that actually is the first thing that your doctor should do. If you have these, mild departures in your liver enzymes, and assuming you're asymptomatic and there's nothing else, no other red flags, yeah, just repeat it. Whether it's a week or 2 weeks, it'll be up to you and your doctor. So that's what they did. And yeah, sure enough, when he came back, they had gone up. So this primary care physician got a little bit nervous about that and initiated a workup. And maybe not the world's best workup, but it wasn't bad. So they got hepatitis A, B, and C titers, which is important. Anti-mitochondrial antibodies. Okay, that's basically looking for something called primary biliary cirrhosis, or I think it's called primary biliary cholangitis nowadays, but I still refer to it as primary biliary cirrhosis. It's an autoimmune condition. It can be fatal. It can be actually really, really serious. Thankfully, it's pretty rare. And then referred him for a liver ultrasound, which was normal. So very important. So they looked for the most common infectious causes, meaning these hepatitis viruses. They looked for a kind of a rare autoimmune condition, and then also for structural disease with a liver ultrasound. So they were looking at not just the liver architecture itself, but bile ducts, gallbladder, etc. And that's actually very useful information. So all of that was normal. At that point, they said, I don't really know what's going on here. You need to go see a liver specialist, which is a GI doctor, a gastroenterologist. And Gastroenterologists know a great deal about this sort of thing. That this is their wheelhouse. They do a full. They go to medical school, obviously, and then they do a full internal medicine residency, which is typically 3 years, and then they will go on and do a gastroenterology fellowship, which, if I'm not mistaken, correct me, guys, you gastroenterologists out there, I think is another additional 3 years. So they know a great deal, obviously, about the gastrointestinal system, about the liver, and so the perfect person to send somebody to. This doctor, this GI doctor, apparently looked at this patient, looked at these labs, scratched their head, said, I'll tell you what, let's repeat it again. And if they're still high, then you know what, we're just going to go straight for a liver biopsy. There were other tests, I think, that maybe could have been done prior to getting a liver biopsy, but they weren't done. This GI doc was pretty aggressive. A liver biopsy is like the last thing usually if there's an algorithm that you're following, it's usually the very last thing, but it absolutely can it'll give you most diagnoses, especially if everything prior to that is sort of ambiguous and you're not not quite sure what's going on. Obviously, getting tissue and looking at it, having the pathologist look at it can be super helpful. So, so the patient on his own was like, I don't like the sound of this biopsy thing. Here's what I'm going to do. I'll come back and get my labs redrawn in a week, but I'm going to stop everything I'm doing. I'm not going to work out. I'm not going to run. I'm just going to hydrate and I'm just going to rest. So he basically just took it easy for that entire week. And lo and behold, when he came back, his liver enzymes were all normal. So the GI doc, obviously smart guy, at that point realized, okay, this is probably exercise related. So he and the primary care doc decided to just bring this guy back periodically and asked him basically, you can obviously resume your exercise program, but before you get your liver test done, no exercise for 7 days prior. And so according to the article, on every subsequent check, as long as he did that, his liver enzymes were completely normal. And actually, this has been my experience too. Mine corrected a lot sooner than 7 days, but that's typically what they recommend. So that saved this guy having to have an unnecessary biopsy. And, liver biopsies are not, in the range of procedures that doctors do, they're not super dangerous, but they have a complication rate. And I have taken care of patients where instead of the liver, their colon was biopsied, and that's not a good thing. So there can be some issues with liver biopsies. You want to obviously not have one of those unless you absolutely have to. So, okay, let's talk a little bit about LFTs. This will not be a master class on liver function tests, but just so you guys have a basic understanding, when your doctor orders a quote liver function tests or liver function panel, these are the common tests that will be in it. And by the way, the name has stuck and it's not going away, but these really shouldn't be called liver function tests because most of them don't measure the function of the liver. In fact, I can remember getting scolded in Morning Report as a young intern by an Air Force gastroenterologist when I referred to AST and ALT as LFTs, liver function tests. He's like, they're not, that's not what they are. And he was right. The point is, though, the name has stuck, so it is what it is. So basic liver panel, we're looking at ALT, AST, so alanine aminotransferase and aspartate aminotransferase. And I'll just talk briefly about what those do. Something called an alkaline phosphatase, which can be a very useful test, especially in if you're assessing liver injury. Albumin is very useful, looking at the excretory function of the liver, and also like your overall nutritional status too. The albumin can be helpful for that. One that people don't always think about with the liver, but I do a lot as an emergency room doc, is the something called a PT and a PTT. So that's a prothrombin time and then the activated partial thromboplastin time. These are measures of blood coagulation. Many of the factors that are involved in blood clotting are made by your liver. So if your liver is compromised, and so it usually has to be fairly severely compromised, then you will have trouble with clotting. and not excessive clotting necessarily, but you will have trouble with your blood clotting. So you're at risk for spontaneous bleeding. The risk of invasive procedures goes way up. I deal with this like almost on a daily basis because we have a lot of people with liver cirrhosis that obviously end up in the emergency department. And it can be really touchy because those people get very sick. And when you're very sick, a lot of times we need to do some potentially dangerous invasive procedures on you, such as putting in central lines, draining fluid out of your abdomen, that sort of thing. And so we want you to be able to form a clot so that you don't bleed as a complication from that, and bleed either externally or internally. And this is a big problem. And then, of course, the thing that complicates that is a lot of these liver cirrhosis patients have very low platelets too. So sometimes we have to transfuse platelets. It's still really dangerous. I get nervous every time I have to put a central line in one of these cirrhotic patients because it can be a little risky. The other ones are your bilirubin level. So that tests a number of different things, not least of which is like basically the metabolic function of your liver. It can be abnormal in other causes. There's other reasons for your bilirubin to be elevated, and so that's why many docs will, depending on what's going on with the patient, fractionate the bilirubin out. It can be conjugated, unconjugated. It's not that important for the purpose of this talk, but other things besides the liver can raise your bilirubin levels, like hemolysis of your blood cells, etc. And then a test that maybe it's not always included right out of the gate, but can help tease things out a little bit, is something called a GGT, which is a gamma glutamyl transferase, so GGT test. I use that mostly if I've got somebody who's got an elevated alkaline phosphatase, and I don't know where it's coming from, because it can come from other places. Typically it's either bone or the liver, and I'm not quite sure. If the GGT is also very high, that would suggest that we're dealing with a liver issue rather than a bone issue. It's not always 100% there, but that's typically where I see it used. And then people that use alcohol, either like binge drinkers or chronic alcoholics, typically will have elevated GGTs. So I suppose you could use it for that too if you were suspicious of that. But that's kind of like the basic liver function panel that you will get when you go see your doctor. And again, if you have specific liver-related symptoms, there may be some additional specific tests that they will want to order, and I'll talk a little bit about those at the end, with in terms of what a proper workup is for these elevated liver tests. But that's kind of like the basics, the bare bones, and then based off of which one of these is abnormal, we'll send your doctor down a different pathway, looking for specific conditions. So as far as AST and ALT, for you biochemistry nerds, they catalyze, as you can see here, they catalyze the conversion of L-alanine, alpha-ketoglutarate into L-glutamate and pyruvate in the Krebs cycle or TCA cycle. It makes sense, right, that these are not necessarily, they're not just isolated to the liver, right? The Krebs cycle occurs in all tissues of your body for the most part, with a few exceptions. And so, issues with tissue outside of the liver can cause these AST and ALT values to be high. It can be difficult sometimes to distinguish whether, if you have an high AST and ALT value, whether it's necessarily coming from the liver. You have to kind of look at this as in a holistic manner, and take a look at the patient, and obviously take a very good history, because as we'll talk about here in a second, muscle tissue, including cardiac tissue, is a rich source of AST and ALT, and when it's damaged, that leaks out into the bloodstream, and you can detect it, and it could, if you're not aware of that, lead you down a pathway where you're starting to do some unnecessary testing, which is kind of what was about to happen to this person in this case report. So yeah, just to wrap that up, AST and ALT. So I mentioned skeletal muscle, cardiac muscle, obviously in the liver, but also kidney, brain, and red blood cells also have fairly high concentrations of AST and ALT. ALK-Phos, as I mentioned earlier, is found in high concentrations both in the liver and in bone. It's also found in the intestine, and one of the sources that unless you know this, could also lead you down a pathway to unnecessary testing is in pregnancy. The placenta makes huge amounts of alkaline phosphatase. So, if you're a physician or a mid-level and you're not familiar with taking care of pregnant women, you may see that and get a little bit nervous about it, maybe refer them inappropriately, etc. Children, especially teenagers that are growing rapidly, will have elevated alk phos levels. You see that all the time in pediatric patients. It does not represent a pathological condition of any kind. It just means that these kids are growing, and that's completely normal. The GGT is fairly specific for the liver, but if you have issues with both your pancreas and your kidneys, you can sometimes see some GGT elevations as well. But GGT is a good one if you really are honing in on a liver process. So it can be useful in that regard. Okay, this is a good slide here. So when your AST and ALT are elevated, the degree to which they are elevated can actually help your doctor hone in on a differential diagnosis and hone in on exactly what's going on. So if AST and ALT are through the roof, and I see this periodically in the emergency department, we're talking like over 1,000 in some cases. There's a very limited number of things that will do that to somebody acutely, and the two big ones are like an acute toxin exposure. So people that overdose, for example, on acetaminophen or Tylenol or other like potentially liver toxic drugs. If they take a huge quantity of that, they'll sometimes see like, it'll be like 10 times plus the upper limits of normal. So very, very, very high AST and ALT. And then the other thing is something called shock liver, which is like an ischemic injury where basically for a period of time, the liver does not get enough, it doesn't get adequate blood flow. And so like, large sections of it begin to die. And so those dead cells obviously release huge amounts of AST and ALT. So a good example of that is maybe somebody who had a prolonged cardiac arrest. That's probably the most common time that I see it. If they're in, I've seen it a few times in septic shock. So people that are, severely, severely ill, they're hypotensive, and the body is sort of shunting blood to the core and not out into some of the peripheral organs, and so the liver can take a hit there, and especially if they're not adequately resuscitated, the AST and ALT can shoot up really, really high, and that's a clue usually when they're that high. There's usually something like that going on. I have seen super high levels like this with certain types of viral hepatitis as well, because that's in the mix. So not things like hepatitis C per se, but I can think of a case years ago. I had a woman that had AST and ALT values like both over 1,000, and it ended up being a CMV virus, so cytomegalovirus. And we didn't find that out till like 2 weeks later because it took forever to get the test back. And at that point, she was already better. So what happens with those people, there's their AST and ALT, they just shoot through the roof, and then they like rapidly correct, once you fix the underlying process. And they actually, a lot of times they do okay. If you have, let's say, acute obstruction of your bile duct, so let's say you got a big gallstone or a common bile duct stone, etc., then you're looking at levels that are like 5 to 10 times upper limits of normal potentially. But they will also have high bilirubin. So the bilirubin will start to build up. So if you have both of those, then you're kind of looking at more of a biliary picture. I see a lot of alcoholic hepatitis, and those people, they can get high liver enzymes sometimes, but they're not like in the high hundreds and thousands. It's usually they've got 200 or 300 for AST and ALT, very common, and their bilirubins a lot of times are elevated too. Obviously, there's a wide range there. There are plenty of people with cirrhosis, that's sort of like burned out cirrhosis, that have normal AST and ALT because they just their liver is mostly scar tissue, and so there's very few healthy cells to even produce AST and ALT anymore. So you can get fooled by that sometimes. But anyway, this is the chart here, and that's just an FYI for you. Okay, so let's talk about exercise. This is a pretty cool little study that helped kind of drive this home for me. So what it talks about in here, it talks about the half-life of AST and ALT. So half-life in circulation for ALT is about 47 hours. So it's a little bit more longer lasting than AST, which is like 17 hours. So in this 2007 article here, British Journal of Clinical Pharmacology, muscular exercise can cause highly pathological liver function tests in healthy men. Or they can, I would correct that and say, it can appear that they're highly pathological. This doesn't represent true pathology, but rather it's a lab abnormality that it should make you think about certain pathologies, but in and of itself is not necessarily pathological. So what they did here is they took 15 perfectly healthy young men, but these are young men that have never weight trained before. They may have done other forms of exercise, but they have never weight trained. And they put them through a really intense, like hour-long training program, upper body, lower body, trained them to failure. And then they checked a whole bunch of different blood values, including liver function tests. And this is what they found in these guys. So as you can see here, on day one, big rise in AST and ALT, and which peaked with AST. It looks like it peaks around day 4, and then ALT not too much later than that, between like days 4 and days and 5, and then you see a gradual like downsloping. But at day 7, many of them, not all, but many of the subjects still had elevated AST and still had elevated ALT. So the recommendation here was to wait a minimum of 7 days in weight training athletes in order to, if you're going to repeat liver function tests. And I think that that's obviously that's a pretty good. I think that's a pretty good recommendation. Now, what I would have liked to seen is this study repeated in well-conditioned, well-trained athletes. My suspicion is that both the peak in AST and ALT and the duration, obviously, that it's detectable is going to be less. And that's been my own experience. Typically, if I lay off of all training for it takes about 3 days, because I've done this many times. Within 3 days, my liver function tests are back within the normal range, and then I just go back to the gym. But if you're untrained, obviously it makes sense. You're going to have a lot more muscle damage in an untrained person, and so those enzyme levels, not only are they going to be higher, but they're going to persist for a little bit longer. So the conclusion, I like the conclusion on this article that they said. So I'm just going to read it here to you. It says the liver function parameters AST and ALT were significantly increased for at least 7 days after the exercise. In addition, so they checked other things, LD, which is lactate dehydrogenase, and in particular CK, creatinine kinase, and myoglobin. These are markers of muscle breakdown, showed highly elevated levels. So they were all correlated together, which makes sense. It tells you this is coming from muscle and not from liver. If this was just from liver, you should not see high myoglobin, you should not see high CK levels, or necessarily lactate dehydrogenase, although that can be a little bit problematic. But regardless, they said these findings highlight the importance of imposing restrictions on weightlifting prior to and during clinical studies. And there we go. Intensive muscular exercise, i.e. weightlifting, should also be considered as a cause of asymptomatic elevations of liver function tests in daily clinical practice. Boom, there you go. So absolutely. So any of you guys out there that are providers, this should be on your differential when you see an otherwise perfectly healthy person coming in with these minor LFT elevations. Ask about their exercise protocol, and that could save them having to have a lot of unnecessary workup. So speaking of the workup, so this is a flow chart here that comes from that paper, and it's pretty good. Like, some docs might do things slightly differently here, but I think that this is a reasonable and a logical way to proceed with somebody to kind of work up these abnormal liver function tests. So it's a little bit different than the algorithm that I use in my head, but not substantially. So here we go. It starts with patient with mild alteration in aminotransferase levels. Okay. Next one is consider the clinical context of enzyme abnormality. So this is probably the first mistake that many clinicians make. They don't take a good enough history. They perhaps don't think about the exercise component of this, but you have to ask about nutritional supplements. You have to ask about prescription drugs. You have to ask about travel. There's a whole list of questions that need to be asked. And then, based on that, if it looks like it's extrahepatic, as they say, there's something else, something outside of the liver, like exercise, then you can either choose to work that up or you can just say, we're done here, depending on what it is. Okay, the one to the right here, history of alcohol, medication use, or both, very common. So yeah, avoid alcohol or medication. So stop whatever medication you think could be causing it. Have them stop drinking alcohol if they can. And then just recheck it. So that's always the first step, is to recheck these labs in a week. Again, if they're exercising, have them stop exercising. If they're on a medication, stop the meds. Alcohol, stop the alcohol. And if it normalizes, then you don't necessarily need to pursue that any further, unless something else comes up that you're worried about. If it's still there, okay, now we need to start investigating this a little bit more. I talked briefly about tests for different hepatitis viruses, so A, B, and C. Depending on the clinical picture, your doctor may test for all of those or just one of them. Hepatitis C is something that can kind of smolder for many decades and is a very common cause of cirrhosis, although I think we're seeing less of it now. A big one is hemochromatosis. Like that's actually, I include that personally. I look for that like right out of the gate in many people, because it's just so common, and especially in like Northern European populations. So they say increased transferrin saturation and ferritin. Yeah, then you pursue a workup. You do this HFE gene mutation testing, and then basically go from there. And then they say here, middle-aged woman with concomitant autoimmune disease, you're going to look for autoimmune hepatitis. So they recommend getting something called an ANA, anti-nuclear antibody, anti-smooth muscle antibodies, and this anti-LKM, which is liver kidney microsomal antibodies. It doesn't have to be a middle-aged woman. Men get these conditions too. They're just a bit more common in women. So now, and then finally down here, if all this is negative, then you start looking a little bit for things that I guess you could call it their zebras, so a little bit less common, something like Wilson's disease, okay, which is a genetic condition of abnormal copper metabolism. It's pretty rare. I've seen 2 cases. I personally have never diagnosed it, but I've seen 2 cases of it in my career, and it highly variable presentation. A lot of times it's like neurological deficits, maybe some psychiatric issues with it, problems with movement. I can think of one guy who had heavy like basal ganglia involvement, so he had a lot of movement disorders, and it can be really devastating. And so there's blood tests for that, copper levels, etc. There's also specific genetic testing. Thing with Wilson's disease is that sometimes you don't even need to get a blood test. You can actually just look at somebody's eyes, and this was on my boards like every single year. So this is what's called a Kaiser-Fleischer ring, which is this like brownish ring around the eye here. Obviously, in somebody with light-colored eyes, it's going to be a little easier to see. So this person has blue eyes; it really stands out. But if your patient or you have brown eyes, it can be a little bit more subtle. So you can see like this is one here where the arrow is pointing. It'd be very easy to miss that just on a routine physical. So your doc needs to kind of be on the lookout for that. So I know some of you are pausing the video right now and running over to the mirror to look to see if you have this. If you do, go make a routine appointment with your doctor. Don't come to the emergency room for it. Get them to look at it and see what they think. So alpha-1 antitrypsin, also pretty darn rare. I'm trying to think. I've never made that diagnosis, but I actually have seen quite a few patients with it. So these people typically will have minor AST and ALT elevations. Their classic finding, at least on board exams, is they develop emphysema at an early age, so sometimes late 30s, early 40s. And so the learning point that we were always taught is, if you get a middle-aged person who's never smoked and they have COPD slash emphysema, and you should check an alpha-1 antitrypsin level, and especially if they have like these minimally elevated liver function tests. And then finally down here at the end, they say consider NAFLD. This is fatty liver disease, or now it's called MOSH. I would I would put that right at the very top of this workup. If you're going to initiate a workup, especially these days, by far the most common thing that I see in my regular practice is when I work up these elevated liver function tests. These days, it's very common for it to be fatty liver disease, like very, very common, because it's a worldwide phenomenon. Soon to be, they say, the leading cause of liver transplant in the world will be um, non-alcoholic fatty liver disease. So it's surprisingly common, and sadly, like I see it in children, which is kind of terrifying. So I have a video on fatty liver disease if you want to learn more about that. It is a big deal. Don't let your doctor blow it off. It is a huge deal. So they have that down at the bottom of the algorithm. My personal feeling is that we should be screening for that like much higher than that. And an ultrasound is a good way. There's other imaging modalities that can diagnose this as well, but a liver ultrasound typically can be pretty helpful as well. So okay, so that's all I got for you guys on the subject. My advice for this, if you're like the person that was in that case study, so you're a otherwise perfectly healthy male who weight trains, which is probably most of my audience, and you have some of these minor perturbations, minor elevations in your liver function test, specifically AST and ALT. I don't want you to freak out about it, but do go see your doctor about it, and if they don't mention it, at least bring it up to them that you'd like to get these repeated. And I can't tell you how many days you should take off from the gym. Based on the studies, I would say give it a solid 7 days until you kind of get this worked out. And if at the end of the 7 days, if things normalize, and assuming, again, this assumes you're asymptomatic, right? If you look in the mirror and your eyes are yellow, that doesn't count. Okay, you need to if it's still elevated, then you need to get it properly worked up. You might want to consider stopping certain medications. I mean, there is the list of prescription drugs and even over-the-counter drugs that can cause liver enzyme elevations is as long as your arm. Big offenders obviously are statin medications, Tylenol. Obviously, if you use Tylenol on a regular basis, even if you don't use it on a regular basis, it can elevate your liver enzymes as well. It goes without saying, no alcohol whatsoever for those 7 days. And NSAIDs too, like ibuprofen and things like that. If you're using things like that on a regular basis, in some cases that can raise liver function tests. There's antibiotics that can do it. Like the list of potential offenders is like way too long for me to go into in this, but just keep in mind, like almost anything can raise your liver enzymes. So if it's safe for you to stop it, ask your doctor first. You may want to do that for that period of time when you're not exercising, and then when you go and get things rechecked, and then you can start slowly adding things back in and maybe kind of pin it down, like what is it that's causing my liver enzymes to be high, and you can work that out with your doctor. Now the question I know I'm going to get, and maybe some of you guys have been told to do this, is like, if you're on TRT, do you have to stop TRT? And the answer is no. Unless there's some reason, always follow your doctor's directions. But listen, injectable testosterone esters at physiologic doses are not associated with increased liver enzyme, perturbations in the vast majority of cases. That would be like the last thing that I would look for or blame. Although I understand there's probably some doctors out there that would point to that immediately. Now, if you're on orals of any kind, if part of your TRT protocol involves oxandrolone, even though I get it, it's relatively benign as far as oral agents go. In terms of the liver, I would consider stopping that as well, because we're all a little bit different. Just because other people don't get liver enzyme elevations with oxandrolone doesn't mean that you will not get them. So I would consider cutting that out. But regular testosterone, I would not blame that for your liver enzyme elevations. That would be one of the very last things that I would look at. So I would take 7 days off the gym. I'd eliminate all medications, supplements too. So this is a big one. There's actually a lot of papers on this. There are a lot of case reports of people having sometimes like really serious liver issues, including like fulminant liver failure from these weird, like idiosyncratic reactions to various herbal supplements or to like a contaminant that was in the supplement itself. So many of these things come from China, they come from other places where there is perhaps not as much quality control and oversight. And so, yeah, you just don't know. There's plenty of case reports of people having major liver issues from that. Okay. Again, fatty liver disease, super common. Hemochromatosis, not that uncommon. Definitely worth looking into. If your ferritin is up and your iron saturation, which is your iron over your TIBC, if that is above, I usually use 50%. Some people say 48%. If it's above that, your doc should probably pursue a workup for that. I actually find that quite a lot. It's at least 2 or 3 times a year. And again, it goes without saying, alcohol, major offender. So just cut out the booze, guys. It's just it's not good for you. Try your best to limit that. So if you guys have any comments on this, if you have experience with the medical system working up your abnormal liver tests, or if you've ended up having some unusual diagnoses or found some uncommon supplements or medications that have caused liver issues, yeah, please share those in the comments. I find them interesting, but other people that are listening and watching these videos might actually learn from your experience as well. So yeah, please feel free to share those, and I will catch you guys next time. Bye.
All Man Medicine video and audio has been created and shared online for informational purposes only. This podcast does not constitute the practice of medicine or professional healthcare services of any kind, including the giving of medical advice. I am not your doctor. No doctor-patient relationship has been established. This content is not meant to be a substitute for professional medical advice and should not be relied upon solely for that purpose either. The only purpose of this content is to present peer-reviewed, research-backed health information for your consideration. As always, rely on the advice and guidance of your personal physician before undertaking any activity presented here, and if in doubt or not comfortable with said activity, practice discretion. Your health is your responsibility and not ours. Finally, I take conflicts of interest seriously. I accept no compensation whatsoever from any private corporations, including pharmaceutical or supplement companies. You can trust that if I recommend a medication, product, or service, it's because I genuinely believe in it and not because I'm being paid to endorse it.